Anyway, thank you guys. I assume you got an introduction to this, to the mechanisms of this. So guys, thank you for setting this up. Can I take this off, or do you want me to leave this on?
You can take it off.
Take it off.
Take it off.
Yeah.
Everybody good with it?
Yeah.
Thank you. I think I had this on the whole time in the car as I was talking. Anyway, so first and foremost, guys, thank you for setting this educational program up. This is, just so you guys know, it's a big deal to have the opportunity to provide this kind of care for our patients here. Not every hospital in the capital region has this ability, so for us, in where we are and the service we provide, this kind of completes that piece where we have the opportunity to provide complete carotid care, endarterectomies, bypasses, and stents for patients, not just high-risk patients, but all patients. This will be done through a registry, just to give you guys a little background to this. Essentially, there is a registry that the Society of Vascular Surgery and Silk Road has created through an organization that's BQI, which saves all the data. And I believe to date, there are probably close to 5,500 cases in that registry.
50,000.
50,000.
50,000.
That's worldwide.
Well,
That's
yes,
US.
absolutely. Yeah, U.S. Yeah. Well, worldwide. I mean, anywhere that is being done, 50,000 cases.
50,000.
Yeah.
In the US, how many?
Around 50,000, because most of them are done in the United States.
Gotcha.
Yeah.
All right, I'm off just by 1 0.
It's okay.
So essentially, you can see that this is disseminated quite a bit into the United States, and it's become pretty much mainstream. So our job today is to, of course, introduce you to the mechanisms of how the procedure is done, and also how this is carried through the throughput of the entire procedure as we do it, as we book the cases pre-procedure, as they come in to see you guys, as the procedure is done in the operating room, and as patients are discharged and how they're followed up. So just before we get into how the procedure is done and how patients get here, there's subtle differences in patients that when we evaluate them in office that we look for, and those are really, in general, carotid endarterectomy. The surgical technique has existed since 1950s, so it's something that most vascular surgeons are very comfortable and familiar with. Carotid stenting is something that is evolving, and over the course of time, even though I might lead as we start this process here, I'm hoping that other vascular surgeons, my partners, will start to do this also over time. And it's just a matter of getting credentialed and getting more experience. There's some subtleties about doing carotid stents that are very different than endarterectomy, so it just requires a little bit different thought process and maybe a little different approach, and we'll go over all that. The only difference that you guys will see by the time patients get to you is that all patients, unless there is a reason for them not to be, will be on dual antiplatelets. So they're on aspirin and Plavix or Brilinta. If they're on an Eliquis or anticoagulant, then we're usually okay with them being on one other antiplatelet. But if they're not on an anticoagulant, then they will be on two antiplatelets. And if they're not, then please just raise a red flag, especially when patients come out here, because they should already have been getting that because the stent's already in by that time. Outside of that, the way the procedure in itself is done and what we let the patients know is the following. Carotid stenting and carotid surgery have been compared head-to-head in many arenas. They've been compared through different devices and different technologies over the course of probably last 20 years. And what we have noticed in data sets that have been generated in trials that were done in 2000, 2005, 2010, 2015, and now with Silk Road, is that if you take a look at the complications of carotid stenting, if the complications of stroke and death and heart attack were in the high range, like 6-7% range, in 2000, they went down to about 5% range in 2005, went down to about 3-4% range in 2015, and now with this device, new technique, they're down to in the 1 to 2% range, depending on how you measure that. The endarterectomy had always stayed in that range, and there are a lot of different data sets. I won't bore you with it, but in general, carotid surgery and carotid endarterectomy at many levels is considered very comparable through this approach. Not necessarily through the approach where we go in from the groin. When we go in from the groin to put in a stent, we have to travel in across the arch get access into the carotid artery, pass a wire across the lesion and put in a filter. Usually that filter acts as the neuroprotection device, so when we deploy the stent, any debris that's generated is captured in the filter. Now just imagine the steps going across the arch, which is where a lot of times the disease is in the great vessels, and then traversing across the lesion as careful as we want to be. We know that through studies done where we monitor the brain to see how brain is capturing hits when embolic debris is breaking from the carotid arteries. Every time we do these steps, there are hits to the brain. So the natural evolution of this was very straightforward in that why not create something that avoids all this? As a personal vignette, I'll tell you, the guy who invented this device was my senior fellow when I was at Montefiore in 2000 and 2001. So he was behind the scenes working on the initial concept of not going from the groin but going in from the neck, and that was initially acquired by Silk Road, and then it was developed into what it is. His name is David Chang. Anyway, so back to this. The way we will do these procedures is when you come into the operating room, you have some sense of how the setup is. Instead of making an incision in the neck, we'll make an incision at the base of the neck. This makes it much more comparable to a carotid surgery and avoids all these other things. When we measure carotid stenting to carotid surgery, the measurements in the past, prior to this device being available, were really based on comparing it to transfemoral approach, where we're going from the groin. And when you compare those approaches to events that are stroke, heart attack, stroke, death, and MI, those are the three things. And now the fourth is cranial nerve injury. When we do carotid surgery to when we go from the groin, there's a big difference in cranial nerve injury, because when we do a transfemoral approach, we're not touching the neck at all. So cranial nerve injury from a femoral approach used to be much lower, of course. But when it came to heart attacks, of course, the stress of surgery was more, so that was higher. When it came to strokes, when we compared carotid surgery to transfemoral approach, the strokes were slightly higher with the transfemoral approach, because we had to traverse across all this, put a filter wire across that lesion to deploy the basket. And when it came to deaths really occur in patients that have either a massive heart attack or massive stroke. So whoever that patient becomes is how that really plays out. So overall deaths are usually comparable if you measure them equally, but it's really the stroke and the MI that were big, that had large differences. What this device has done now is eliminate all those steps. So because we go in directly from the base of the neck, and I'll go over the steps with you, we've eliminated or decreased the incidence of stroke. So in data sets that are comparing the stenting with TCAR, with flow reversal system to carotid surgery, when it comes to stroke, death, MI, they're very comparable. As a matter of fact, some would start to suggest in these national data that are coming out that TCAR might have advantages in certain arena. Now, those advantages are easy to list if you compare large data sets, but really those advantages become more critical when we look at the technique of how we do things locally. So this is not just about us bringing a product and deploying a stent in someone, but how this will be done in the procedure room makes a lot of difference on what the outcomes really will be. I'll share some data with you on what we have already done. So in the last 5 years or so, we have done about 700 carotid procedures. And in those 700 carotid procedures in our practice, about 600, probably close to 700 were endarterectomies, and about 100 are these TCAR procedures that we have done at Glens Falls Hospital. And in comparing those, the incidence of stroke with carotid endarterectomy is slightly less than 0.5%. The incidence of heart attacks is about 0.5%. Death, thank God, is in asymptomatic 0. In symptomatic patients that have had massive strokes that we're trying to rescue, those patients sometimes don't survive because they've already had a massive insult that we're behind the 8 ball. In comparing the close to 100 procedures that we've done with TCAR, we've had no strokes, deaths, and MIs in those patients. So the procedure works really well, and our goal is to set up the stage at Ellis to do it exactly that way. And what you guys will see is a transformation of carotid endarterectomies that will very quickly evolve towards TCAR. So this will become, a chance that we'll be doing 50% carotid endarterectomies and 50% TCARs is probably going to occur very fast over the next several months or so, is what I would think. So that's that. The way we do that procedure is patients come into the operating room, they lie down exactly like they normally do. There is no cervical block. You could block this area, but the incision is lower. It's a little bit difficult to do that block, and patients still feel, some of what we do. So in general, we will do this under MAC. Patients will just, get some fentanyl, Versed, whatever the drug of choice is by the anesthesiologist, and they'll be snoozing so they're comfortable. We'll give local anesthesia. The incision is made just over the clavicle bone here, where the sternocleidomastoid meets. The incision's about 1 inch long. Could be smaller, could be larger, depending on the anatomy. We go in and we get the common carotid artery exposed. When the common carotid artery is exposed, the thing to watch for there is the vagus nerve that sits right next to the artery. So we mobilize the nerve away. We put a vessel loop around the artery only, and we pick that up. Once we have access to that, the vessel loop acts really as a clamping of the proximal artery. So if we were to just tighten that vessel loop, the artery would be clamped. That's one piece. We are not clamped yet, we've just put the vessel loop. Once that is situated, at the same time, if we have a second surgeon, they will get a femoral venous access. If we're doing a right carotid, the way the device sits best is if the left femoral access is obtained, and vice versa. If we're doing a left carotid, the right femoral access. Although it's not that important. A lot of times you'll just, it's easier to stay on one side. So depends on the surgeon's choice, they'll just get an access. The femoral access is a percutaneous stick with a 8 French sheath that goes into the groin. Essentially now we have a femoral vein access, and we have a common carotid that's got a vessel loop around this. Once that happens, we use what, as part of this mechanism, is a micropuncture needle and a micro wire, and then a stiffer wire and a stiffer sheath. We'll get access with a micropuncture needle, we'll get access with a micro wire, and that wire, when we advance that wire, we tend to put the wire into the external carotid artery, so we're not even touching the internal carotid artery. And when we do that, we put the micro catheter over it, which allows us to advance a stiffer wire. I know I'm saying lots of things, but it's relatively simple. A micro needle, micro wire, a micro catheter over the wire, and then a stiffer wire. And the stiffer wire allows us to then engage the 8 French sheath that is built into, you have it here?
Yeah.
Sure, here. This one.
Oh, well, it's already in.
Yeah. Pick it up.
That, it's not bleeding. So, this essentially is the catheter system. It's got a stop here that you can see, and sometimes we will take that off depending on whether we are going to penetrate the skin outside the artery to travel in, depending on where we're getting the carotid access. But I would say in vast majority of the patients, we directly can move the carotid out of the incision enough that we can get access directly into it. And once that is situated in place, there is a little lure here that we can suture in. So we'll ask for a silk suture. We'll just suture that into the drapes. What that does is that just secures it, because the sheath is only in by about 1 inch. And what we don't want is for the sheath to fall out accidentally as things are moving. So we'll secure that sheath. As soon as these things happen, the mechanism in the back comes separated. So essentially what we will have is a femoral sheath that's in place now, and this system that's in place. And this device will be then connected to the tube. We'll connect the arterial end first. This is the end that's closer to the patient's neck, and the longer port is the one that goes to the vein. As soon as that's connected, you can imagine that the carotid has a higher pressure, the veins have a lower pressure, so the flow is reversed automatically. So now we're in a position that the blood, as soon as we clamp this and undo this stopcock and connect the two, the blood will automatically start to flow from the arterial end into the venous end, even if it's straight or even if it's elevated, because the blood pressure will drive that. There are 2 switches back here. One is low and high. That just means that the blood will flow faster. There's a mechanism here that opens that up. And the other is just a finger, my ability to stop that. I'll probably be the operator is pretty much the only one who's handling this, so you guys don't have to worry about that. We're not going to ask you to maneuver that, because it's sitting right in front of me, and we want as little movement as possible. Yeah, if you guys move this, it'll zap you. So don't touch it. So with that, I'll automatically put this on high because we just want this to work quick. And when that comes all the way to the end, the surgeon is going to connect these two ports, and they'll flush out the air if there is any, and then the mechanism is connected, and now the flow is ready to be fully reversed. Now remember, even without us clamping the carotid artery, pulling up on that vessel loop, we already have a flow reversal. But you have antegrade flow also, so the flow that's coming back is mostly that's coming in from the heart into the carotid artery and getting reversed and going through these systems and coming to the groin, not necessarily from the brain. There might be stagnant flow here at this time, because remember, there's a lot of blood coming up, and it might not be able to all go at a speed that we wanted to through this system. It depends on what patient anatomy it is that we're dealing with, large vessels, small vessels, etc. So with that, when we are ready to do the procedure, the back table will have a whole setup, and we will go over that with you. These guys will be there, you know, probably every case, but especially in the beginning, they'll be there for every case. And once again, on the back table, there is a wire that has a little feeder that you put the wire through that goes, that's engaged to the back of the sheet. And with that wire in, then we will traverse that wire, and I will tend to bring that wire up to the common carotid artery, still not traverse it. And when we have the stent that's going to be flushed on the back table, we'll show you how to do that. It's very simple. It's just a stent that deploys very easily by push-pull handle, but it just requires a flushing mechanisms, and I don't know if you guys have that. Maybe we can go over that in a little bit. Once that mechanism is all set up, I will pull up on that vessel loop that's holding the carotid artery, and I'll secure that to the drape just with a just with a hemostat clamp or something. Once we do that, now the antegrade flow from the heart going up to the brain is stopped. All the flow is now from the brain coming down, out into this device, captured into the filter mechanism system, and goes back into the venous system. And what that allows us to do is automatically create a position where the flow is reversed. And we'll check that. We'll do an angiogram. And the way I do the angiogram is when I will inject the dye initially, I'll hold this thing that zaps you guys if you touch it, close. So as soon as I shut that off, now I've stopped the flow reversal. So when I inject slowly, blood will go up, and then I'll release that button, and the blood will come right back out, and we'll see that angiographically. And we know that right there we've established flow reversal. There's probably, you know, a 5-10 second delay from the time we really do the flow reversal, because we tighten this, but that's how it kind of works. And that's when we say we have established flow reversal, is when whoever's record keeping, these guys will help you guys do that. We'll know that, you know, just like when we say carotid is clamped when we do an endarterectomy, we know how much time it is that carotid is clamped for. This will be a mechanism for us measuring flow reversal time. I just asked these guys to give us, on the first 100 or so cases we did, what the flow reversal time is, which means how long it takes to go in, deploy the stent, and be done with the case, and then reestablish flow. I think the average time was 4 minutes per case. So it's quick, right? Flow reversal established, stent placed, deployed. We take a balloon to dilate afterwards, usually, sometimes before, and we'll go over that. We'll talk about it as we're doing the case. Please get a balloon. We need to dilate it before. So the way that works is, now we've established flow reversal. We traverse that wire across the internal carotid artery. We advance the stent over that. We deploy the stent to where we want to deploy it across the lesion. Once the stent is deployed, the mandrel, the delivery system, comes out. That goes in the garbage. I'll ask for a balloon, which will be ready. We'll already pre-ask for that balloon as we're getting ready to do these things. So all those things are already on your table. We advance the balloon. We balloon angioplasty. We take the balloon out. We take an image. If it looks good, we stop the flow reversal, and we're done. We'll take an image of the neck, and we'll take an image of the brain. The reason to take an image of the brain is because if any debris has escaped to the brain, my chance of keeping that flow reversal in and going in to suck out whatever we need to is right there and then. I've done, I think, 100 in this lifetime, and when I was part of the Albany Med group, I had done, I believe, 25 cases. In the 125 cases, the number of times I had to go in and suck out clot was 1. And that was very early on in the first 5 or so cases that we were doing. The device was an older version. It had a little bit more things that needed to be ironed out and stuff. So essentially, that's something that unlikely will ever happen. But we check for that and all those kind of things. And then we remove the device Before putting that sheath in and the wire in, what you'll notice is I'll ask for a 6-prolene stitch. I'll create a U stitch on the artery, and then everything goes through it. So when the device comes out, we just purse string that stitch down and close it. And that's the procedure. Then we just close this incision, remove the sheath, hold pressure. The only thing I didn't tell you guys is as we start the procedure, once the incision is made, we'll always ask the anesthesiologist to give heparin. We tend to give more heparin than we do for carotid endarterectomy, and we'll always give 5,000 heparin. It's somewhat of a made-up number, but 5,000 is pretty generic for most of us. If it's going to work, it's going to work in that time. And I think that's that. The closure is a 2-layer closure and a sub-Q and a dermabond. Here it's just pressure, a little drop of dermabond. Patients will come out and recover here, and they'll go standard way that they have for the carotid endarterectomy. Your care in PACU for the patients will be really no different. You'll look at this wound instead of this wound. You'll evaluate them neurologically like you do for carotid endarterectomy, and it's relatively straightforward. I think that's
one difference in the PACU I think is important to state though is the issue of hypotension versus hypertension. So I would understand that generally with the CEAs that you guys are really looking out for hypertension afterwards. With the TCAR, because there's a stent in the carotid bulb putting pressure on the baroreceptors, that there could be a greater propensity for hypotension. And you'll really want to keep your eyes on that. We do not want to have the patients, usually Dr. Mehta will give a parameter, like I want to have the pressure between a systolic high level and a low level, but you do not want to have the pressure coming down. And as a note about that, in our Roadster 2 trial, we had on the intent to treat group was a 1.9% stroke and death rate. The per protocol was 0.6. And what was discovered when they analyzed the delta between the two was that the 70% of the complications came as a result of patients not having appropriate dual antiplatelet therapy. 30% of the complications were hypotension status post the case. So managing that pressure after the TCAR is critical, and especially that they don't become hypotensive.
So a couple of things. He's right on all those accounts, and that will be a difference that we will notice. We noticed that immediately when we deploy the stent. So patients will either come out on a pressor or not. When they get here, if they're not on a pressor, you'll see that the pressure might be drifting down, and we want to make sure that we maintain that pressure at a certain level. In general, strokes don't occur in patients because they're hypotensive. Strokes occur in patients because if they're hypotensive or there are other things going on, there's platelet and debris aggregation that can occur more readily, and then that can embolize. So even though the data was parsed out that way, my personal belief is that they didn't have a stroke because they were hypotensive. They had a stroke because it was procedure-related stroke, because that's what happens to patients who have stents in their carotid arteries, and we have to make sure that the stents are well anticoagulated and patients have adequate pressures and stuff like that. Questions?
Do we have ACT goals while we're heparinized?
So we'll give the 5,000 heparin. The procedures are so quick, we actually don't even check the ACT.
Okay.
If the clamp times, for some reason, procedure's complicated, we're in there, we know we're going to be doing procedures for a longer time than this 4-minute average flow reversal. That means there's some flow reversals that are 2.5 minutes, some that are 6 minutes. But if we're going into 10 minutes, 20 minutes, 15 minutes of flow reversal, which happens, the average time in the country for flow reversal is about 11, 12 minutes. So even that time is relatively short, that we probably won't check that unless it's a special circumstance. And if we do, it'll already have happened in the operating room.
Okay. So just clarifying for ICU education purposes, don't anticipate ACT checks.
Correct.
Post-operatively. Thank you.
Any other questions, guys? Gals? All right. I think we are good then. Please approach me or Priya or Zach or Phil if you have any questions about this. When we do the first case, which I think is coming up, we have a bunch of cases that are waiting to be done. We'll make sure the day off with the staff in the operating room, we'll break it down. We'll go over this with the techs and everybody else so people feel comfortable. We'll always have 2 surgeons in the beginning, so you guys can kind of learn as we go along, and that's all I have to say. Thank you, guys. Thanks for setting this up. Thank you for being here this morning. Appreciate it.
Thank you.
All right.